Is what?
Your office looks very similar to mine.
It does it? Just a bunch of chaos back there and just chaos. So look forward to seeing you guys next week. It's
Yeah.
Yes.
gonna be a good time. I haven't been to a conference in a while, so it's a big
Yeah.
outing for me.
No, we're excited and we'll touch base offline, but I'll make sure that we can coordinate some dinners and get you
Yeah.
when you're free.
Yeah, for sure. Yeah, I want to prioritize that because I'm trying to actually put together my itinerary right now. So let me
Okay,
know.
I'll text you. I'll text you.
Wait,
All right. Well, we have quite a few patients on, so I'll let you
awesome.
guys go ahead and get started. But thank you to everybody for joining us today. We have Dr. Jason Starr and Dr. Jonathan Strosberg here who will be moderating today's discussion. And Dr. Starr is going to be talking about the importance of seeking care at a NET Center of Excellence. So thank you everybody for joining.
Thanks for having me.
Thanks. And Jason, I'll just introduce you briefly. You're a net expert. We've known each other for quite a few years. You're at Mayo Clinic in Jacksonville, which is one of the three Mayo Clinic branches. I guess the mothership is in Minnesota, but then there's a branch in Jacksonville and a branch in Phoenix. Um, and anything you want to add to that, by the way?
Yeah, no, I think that summarizes it. I did my training here at Mayo and then I left for a little bit and been back for about 6 years. Yeah, really thankful that we started this FLaNET's resource for patients and honestly for us medical providers too, for us to network, collaborate, connect. So it's beneficial for all parties involved. So no, really happy to be here. I love patient education. It's something I'm very passionate about. I love empowering patients with knowledge and allowing them to essentially become patient experts, and what I tell my patients is they end up knowing more than most healthcare providers who don't work in this space, which is something I'm proud of when they're able to speak the language and, understand what's going on with their health.
Right. So, there is some literature suggesting that patients who get referred and receive at least some consultation, if not treatment, at a center of expertise have better outcomes. And maybe you can talk a little bit about what these kinds of centers can offer as opposed to, say, community care.
Yeah, so I tell my patients that I'm in a position of privilege in that, I can focus my practice of medicine, and the great majority of patients that I take care of have a neuroendocrine type cancer. And so the community oncologists do a great job, but it's really hard to know everything about everything. And if you're a community oncologist and you're seeing a patient with a neuroendocrine cancer, and you see, I don't know, 10 patients a year, right? Well, it's not going to allow that oncologist to understand the nuances of the disease. Even something as simple as neuroendocrine tumor versus neuroendocrine carcinoma. I get referrals, and the nomenclature in the chart and on the records is all kind of used intermingling. And at that point, we're not speaking the same language, right? And so to be able to really communicate and to be able to communicate with the patient and to be able to inform the patient of what they have and what the prognosis is and what the treatment options are, you have to speak the language, right? And so I think that that's why and we are, you at Moffitt as well, we're in a position of privilege to be able to take care of patients with neuroendocrine cancers day in and day out, right? So, for example, we have our North American Neuroendocrine Tumor Society meeting next week. We will have a conference for 3 days dedicated to nothing but neuroendocrine cancers, talking about new developments and how we share practice patterns, right? And you're on the front lines in terms of as a physician with the patients, with all the latest knowledge, right? All the nuances, and you bring that into the room for the patient. And it can make all the difference, right? So another example is a multidisciplinary team, right? Moffitt and Mayo and many center, at least academic centers, tertiary care centers in the state and out of the state have nuclear medicine, interventional radiology, a surgeon who specializes in neuroendocrine tumors, an endocrinologist who specializes in neuroendocrine tumors, right? And so you have a team, right? What I notice in the community, and again, they do their darndest, and I did it for a year and a half, and it's really difficult, right? And they do the best they can, and they do a great job with what they have. But the care becomes very fragmented. There's a bunch of different electronic medical records. Scans done here. Oh, we don't have the scan report. We don't have, and Dr. Strosberg and I deal with this even at our institutions, trying to track down records. We were just talking the other day, can you fax things over? And who knows if it made it over there, right? So it's even a struggle within academic institutions, right? So having a multidisciplinary team. And I think one of the key things, distinguishing features or factors that go into seeing a NET specialist, is kind of an overview, right? Allowing that oncologist, that physician, that expert to go over all your records and put together a unified plan, right? Which factors in all of these things that I just mentioned. For example, a pathology review of the slides, right? So Dr. Strosberg and I usually almost invariably request the slides so that our institution can review things. Because again, if the notes are intermingling neuroendocrine carcinoma, neuroendocrine tumor, now again, we're not speaking the language. We don't know what we're dealing with, right? What disease this is, how we're going to treat it. So even having that expert pathology review can make just a huge difference. I'll give another example real quick, and then I'll be quiet for a few minutes. So I saw a patient, and they had a surgery for a neuroendocrine tumor. They came to see me. They were started on the somatostatin analogs that we know of. We talk about them as lanreotide and octreotide, and those are the monthly injections. They're called hormone injections, essentially. And we can talk more about those. But patient was started on this, and they had resection of their tumor. There was no evidence of cancer anywhere. And, I had to kind of educate the patient that, hey, you don't need to be on these injections right now. They had no evidence of carcinoid syndrome, right? And so what happens is, if you go to the guidelines, right, and a lot of the community oncologists use the guidelines do their best, and Dr. Strosberg's on these guidelines, and they do their best to describe nuance, but they don't capture it in every patient, right? So if you go on these guidelines and it says, consider, somatostatin analog, these injections, and you're not quite seeing, because they're usually like a pathway that you follow, and you're not seeing, well, that's really indicated more for stage 4 disease. So this patient would have essentially maybe been on injections indefinitely, had potential side effects, gallbladder disease, so on and so forth. Not to mention the financial impact for the patient and the whole healthcare system. And so, we said, hey, let's hold the fort. We don't need these injections. I just saw the patient today, 2 years later, no evidence of disease and no injection. So just to get somebody to just give you an extra level of reassurance that you're on the right track. And honestly, Dr. Strosberg and I are happy for you to be able to go back to that community oncologist armed with the knowledge after we communicate with, and John and Dr. Strosberg is great at this, communicating with outside providers, and I do the same, and relaying the plan so that it can be executed closer to home.
Yeah, these are all great points and said it very eloquently. And it's really not just your personal expertise, but the fact that there is this multidisciplinary team. So you mentioned pathology, for example. There's a surprisingly high rate of the pathologist changing the diagnosis. Sometimes it's just a little bit, for example, changing the grade, maybe grade 1 to grade 2 or grade 2 to grade 3 or vice versa. But sometimes it goes all the way from, correcting a poorly differentiated neuroendocrine carcinoma into a well-differentiated neuroendocrine tumor. That's rare, but, I've seen it happen where patients have received chemotherapy that that was, inappropriate for their cancer. You talked about kind of a shared model of treatment where, The patient may be getting treatment with their local doctor, but still coming to you for consultation. How often does that happen? Is that majority of your patients or?
Yeah, so I would say based on the referral patterns and the locations that I see patients from, it's probably about 50% of my patients. And I actually encourage them to find somebody locally because, and we emphasize this a lot collectively, is like quality of life. If you're getting the same injection and you could be close to home and you don't have to take a day off work or you don't have to go out of your way to make it over here to Jacksonville and you live 2 hours away for a monthly injection, I encourage it, and some patients have a certain comfort level that they want to be here, where we are at Mayo in Jacksonville. And some patients are like, hey, that sounds great. So I usually encourage it. And yeah, it's about 50% of my practice.
Yeah. And somatostatin analogs are something that can easily be given in the community. I mean, sometimes there's issues with nursing.
Yes.
Comfort with giving the shots, and surprisingly, we see often that patients who get into community, they draw blood tests on them prior to each cycle, which is not necessary. But that would be an example of something that's easily done. On the other hand, there's more specialized treatment. So, for example, peptide receptor radionuclide therapy with Lutathera. That's something that is not easily available in the community, and community oncologists are probably not, or radiation oncologists are probably not comfortable administering. There's really no nuclear medicine doctors in the community, or very few. There are some radiation oncologists, but this is definitely outside of their wheelhouse in most cases. And then other things like embolization, liver surgery, other surgeries, probably best getting done at institutions where it's done frequently.
Yeah, and to that point, I think volume and time reign supreme, right? I always tell patients, like, as I've been doing this longer, I get more wisdom because I have more experience, right? And nothing can replace that. And similarly to a surgeon who's been doing a surgery, a Whipple procedure, for example, is one of these pancreas surgeries that we always talk about, who's been doing it for 10 years, probably and doing it every week, gonna have better outcomes than somebody who's been doing it a few years and does a few a year, right? So to that point, you want to be at a place where that the patients such as yourself are being seen day in and day out, because invariably you're just going to get better care because there's more knowledge there.
Would you prefer to see patients at the very beginning, their early diagnosis, or after they progress? Let's say it's a straightforward case. And not, there's many that aren't straightforward, but let's say metastatic, low-grade neuroendocrine tumor, non-surgically resectable. They can start on a somatostatin analog. I mean, do you feel it's important to see them early, or do you think after progression is more appropriate?
Yeah, I think early is really important because it really sets the tone, right? It sets the tone for the diagnosis, the prognosis, in terms of speaking the language, having proper diagnosis to start, and then setting the course for the treatment. And it also helps with, well, how often should we do scans? Well, every 3, 4, 6 months, whatever the case may be. Or, hey, I think we need to follow you a little bit closer at first and identify how this is behaving, and then we can kind of space out your scans thereafter. Now, I do tell patients, if you're doing great and you've had 3, 4 scans in a row, right, that look good, you're getting your monthly injections, I want as least interruptions to their life as possible. So I kind of say, like, hey, I'm on standby. You know where I am, where I live most of the time. And if you need me, I'm more than happy to see you. But and sometimes it's more of a reassurance. It's more of a comfort thing that when they come and they get scans here, for example, that they get that extra level of reassurance, and then mentally that helps them, because the mental part of this is I would imagine very difficult. I mean, there's patients where you know what you have, you've been defined, and you're on observation. And mentally knowing that there's something there and we're just watching it, that can be really difficult. So I think that the visits and the frequency of the visits are also potentially therapeutic. Now, the issue that I see sometimes is that patients come to see me maybe a little bit late, in the sense of, oh, where, and I wish we would have done that, or I wish they wouldn't have maybe considered that. For example, whole liver Y90, or and something of that nature. Or wow, I think PRRT, the Lutathera would have been helpful maybe a few years ago, right? So I think, in my estimation, in my experience, that I'd rather see someone earlier and set the course for them, and then have, intermittent check-ins.
Now let's talk about the scans for a second. Do you feel there's an advantage to getting the scans at your center as opposed to locally?
Yeah, that's a great question. Yeah, so for PET dotatate, I have seen, or any somatostatin receptor imaging, copper 64 dotatate, or gallium 68 dotatate, which is the two most commonly used. I have noticed that there can be some variability in quality, mostly related to the timing of the imaging based on as it relates to the injection of the radionuclide. And so, for example, the liver, a lot of times if you wait too long and the radionuclide's been sitting in there, the liver pictures are just not gonna, you got so much what we call background, because we have these receptors normally throughout our body. We want to see a differential uptake or brightness in the areas where the cancer is. But if you don't do it quite right and the timing isn't right, it's not optimal. So with that being said, I'm okay with patients having PET dotates or somatostatin receptor imaging done outside, even though it can be suboptimal. Now, the other, I guess I want to make 2 points here. I don't follow patients typically with PET scans, right? I like to get a PET scan at baseline. I like to get a PET scan if we're considering PRRT. I like to get a PET scan if we're, trying to find the primary tumor. I like to get a PET scan if there's bone metastasis and we're following that. But a lot of times I'm looking at the liver. And for liver metastasis, PET imaging is not the best. So I prefer MRI, and I think that, and Dr. Strosberg can comment on this as well, I think that's maybe unique at Mayo, and Moffitt, I think you all do a lot of MRI too, but I'm very keen on some of the images that the MRI gives, which we refer to as diffusion weighted imaging. And what the diffusion weighted imaging does is it allows us to see the metastasis that's obvious in the liver, or the areas of spread we call metastasis. But it also allows us to see very small millimeter disease. And I think this is important because when we're making a decision on surgery or a liver-directed therapy, I think you really have to know you have to have a lay of the land, if you will. You have to know what's going on in the body, where is the disease? Because if you're considering a big liver surgery and the MRI shows that, well, there's a lot of disease in the left lobe, but we're going to go after the right lobe, does that make sense? Do we have other options aside from surgery at the moment, right? So I prefer MRI. If CT is going to be done, please ask your local oncologist to do dual phase contrast. So the important thing there is that they do an arterial, we call arterial phase, and a venous phase. Sometimes these tumors only show up on the arterial phase. If a patient wants to do scans locally and I'm following the liver, I much prefer a CT because there's more homogeneity, more consistency with the technology. If they're coming here, I prefer MRI. PET can be done outside.
Right. But if you ask for dual phase or triple phase, as is often the case with non-contrast, how often is that actually getting done? I mean, it seems kind of hard to get that into.
It's very hard. I don't think that my relaying that gets, properly relayed. So it doesn't happen very often.
Right. So I guess my point is that, it can be quite convenient for patients to do scans locally and do televisits. I'm sure you guys are doing televisits as well.
Oh, yeah.
Definitely makes things harder for us in many cases. Chasing it down is surprisingly hard, even in 2024. You would think our medical system would be more efficient at transmitting information, but they're still stuck in the 20th century with faxes and mailing stuff by FedEx. Not everywhere. I mean, there's a lot more institutions that can transmit scans electronically, but it's still a lot of stuff is being done by mail.
It could be painful, and I do explain to patients that caveat. Hey, if you do the scans locally, we may do our televisit, and I don't have them.
Right.
And
But also, it's there's less consistency in terms of the same technique, the same machine, et cetera.
Yeah.
So that makes things a little bit more difficult. But the good thing, I think, these days, as far as net centers in Florida, at least we've got, the major regions covered, I would say, finally.
Yes, South Florida's covered.
Yes. We have you in North Florida. We're in the center. Dr. Chauhan, Aman Chauhan's at University of Miami. So it's I think, a reasonable network.
I'm really happy about access for patients in that regard.
Yeah. So I don't have any other questions. Do you have anything to add? Otherwise, we can see if any patients have comments or questions.
Yeah, I would say a few comments on like clinical trials that we have at Mayo, and maybe in a lot of these that we have at Mayo, Dr. Strosberg has at Moffitt, and even more, he might have a few more that we don't have. So one that I think is important to highlight would be what we call alpha particle therapy. I think, this has probably been discussed many a time in this forum. So essentially, what we have right now, Lutathera, is beta particle, right? And so we're hoping that alpha particle, and I won't get into too much of some of the details or the science, but essentially, we think that it's a more powerful energy source and it can damage the cancer cells more so than the beta, right? To be determined, but some of the data suggests that, right? So right now we have a trial that is looking at alpha particle therapy versus what we would call standard of care. And standard of care in this setting can be a number of different medications that you would discuss with your oncologist. And patients are randomized. So I do a little clinical trial education. So randomization, it's a computer generated process, right? So you sign a consent for the trial after you go over what we call an informed consent. You understand the trial, you understand what the risks are, all these things, right? We make sure you're what we call eligible for the trial, which is based on a number of things: lab parameters, kidney function, liver function, blood counts. And then it goes into a computer, and the computer, quote, spits out the result in terms of the coin flip. And in this trial, it's a 50% chance you get the alpha particle therapy and 50% chance you get what we call the standard of care. The nice thing about this trial is that even if you get the standard of care, because I think collectively the patients that I've put on the trial and they've gotten the standard of care, a little disappointed. I mean, how could you not be? You want the alpha particle therapy. I mean, that's why you're signing up for this, right? But if you get put on the standard of care and it's not working determined after a period of time, you are allowed to then get the alpha particle therapy, right? So if you sign up for the trial, you almost certainly have access to the alpha particle therapy, right? So that's exciting. And I think in terms of the next frontier for neuroendocrine cancers, I think alpha particle is one of the more exciting lines of research in terms of where are things going next. And so, I'm looking forward to next week hearing more about other research efforts, because I think for a long time, PRRT, we've really been siloing a lot of efforts into optimizing that treatment, which makes sense because it's been groundbreaking. right? When Dr. Strosberg published, back in 2018 or end of 2017, the initial, results from the trial, I mean, it changed the paradigm of how we treat this disease. We didn't have many treatments for small bowel neuroendocrine tumor, and it completely changed the landscape of the treatment. So it's been a breakthrough. So that trial, I think, is really exciting. And I know Dr. Strosberg's helping with leading some of those efforts with Dr. Hayter over at Moffitt, and we have that trial available here. We have some other trials, but I think that one is the important one to highlight out of the ones that we have at the moment.
Yeah, very, very good point. I mean, in the community, they have clinical trials for common cancers, but almost nothing in the NET space. And so, being able to enroll in a clinical trial, you really have to be at a center that specializes in NETs. And also, potentially not only helping yourself, but also helping advance the field. And, there are at least a few patients on this call today who have participated in clinical trials, and we appreciate that.
Yeah, thank you.
So I see there's a chat from Alicia. The question is, how has lead therapy results been, and how long are they lasting? So we're actually presenting some of that data at the NANETS meeting next week. I can divulge it because it's basically a repeat of an abstract we presented this summer at the National ASCO meeting. But the response rates, meaning rates of significant tumor shrinkage, are high. It's over 50%. So that's better than what we would expect with Lutathera, although, unless you're comparing things head to head, it's hard to know for sure. But it's certainly encouraging. As far as time to tumor growth, it's also looking quite good. The data are quite early, so we haven't hit any point yet where half the patients have progressed. So it's hard to know what that duration of response is, and also it's a relatively small number of patients. So there's almost certainly going to be much larger clinical trials using lead. As far as tolerability, overall, fairly tolerable. People can get quite tired during treatment. There is one side effect that seems to be unique that we don't see with Lutathera, and that is that it seems to cause swallowing issues. A lot of patients get the sensation that food is getting stuck. And it's not quite clear how that's, why this treatment is affecting the esophagus, but we've seen it in more than a few patients. So that's a little bit of a toxicity. It does tend to resolve in most patients over time. So we are encouraged by that. So the lead and the actinium are the two of the main alpha particles that are being tested, as opposed to Lutathera, which is a beta particle. So it basically, as you said, it emits a much heavier radioactive particle.
And it looks like Alicia said her husband had horrible diarrhea, which we can also see with the beta as well. Did it last? I wonder how long it lasted, the diarrhea. I don't know if you could type in there, Alicia. I also heard maybe hair loss more so.
Yeah, so both alpha particles, I think, cause a high rate of hair loss, which
we're not used to.
A joke that we don't really see as a toxicity, but many patients.
For you and I, maybe. 2 months after treatment. Oh wow. All right. Sorry to hear that. The lead-212 trials, both Dr. Strosberg and I have at our centers. I think the big differentiator for that trial compared to the one I outlined before is the lead one. They're seeing patients who have not received PRRT yet, so did not have Lutathera. The other trial, the actinium-225 trial, the one that I highlighted, is for patients who had Lutathera and benefited from it for a period of time, and then the disease started to creep along. So those are the differentiators on those trials. But yeah,
And I
I'm
have to say, diarrhea is not something that we've seen
with
commonly
that.
with this drug, but it's a new drug, and even with old drugs, sometimes we see unique side effects, but with new drugs, there's definitely a higher rate of unanticipated side effects. And obviously, when you're doing a trial, it's important to really make sure that all the side effects are recorded and share it with other investigators.
100%. Please talk to Ron on Tuesday. Okay.
Yeah.
So the other thing is, speaking of diarrhea, I always, that's always a good point of emphasis and education, because I know a lot of our patients are struggling with loose bowels and diarrhea. That one can be difficult to elucidate the cause, because a lot of times we will kind of get sometimes we have some tunnel vision, and because carcinoid syndrome, diarrhea, right? But we know, those of us who take care of these patients with this disease know that there's a multitude of causes of diarrhea in this setting, right? One being bile acid diarrhea, right? So small bowel tumors, most common neuroendocrine tumor occurs in the ileum, right, where the small bowel and the large bowel meet. And when that area is removed, that's the area where bile acids are reabsorbed into the body. And if you don't have that mechanism to reabsorb those bile acids, that recycling, they come out in the stool, and they're your body wants to get rid of them. They're kind of acidic. And so in those situations, we try bile acid sequestrants to kind of bind up the bile acid. So that's a common cause of diarrhea that I see that is overlooked. So worth mentioning, there is a blood test you can do for that to test it, but I typically, I don't always get the blood test. I kind of, listen to the story, see if it fits. The other cause of diarrhea that I see that are really common and maybe underdiagnosed is, the other one is pancreatic exocrine insufficiency. So what does that mean? So the shots that you may be on, the somatostatin analogs, cause the pancreas, I always say, to be lazy. It just doesn't work as well. And so when you eat a meal, particularly a fatty meal, the pancreas squeezes out these juices, if you will. And when you're on these drugs, the somatostatin analogs, the pancreas doesn't squeeze out the juices like they should, or like they normally would. So very often, I would say 50% of my patients are on what we call pancreatic enzyme replacement. And essentially what you do is you take pancreatic enzyme with your first few bites of food, and it helps you digest your food, right? So those two, I mean, there's a couple other ones that, I don't want to, go into too much detail, but those are two common causes of diarrhea that I see that are overlooked when patients come to see me. Because the obvious one is carcinoid syndrome, right? We can measure the serotonin metabolite, and that's kind of, easy to understand. The other ones are more nuanced, and we may be chasing our tails when we're treating carcinoid syndrome, when it's actually something else.
Right, and it's important to also, when you talk about diarrhea, like in some cases, it's caused by pancreatic insufficiency, and which is caused by the somatostatin analogs, but many doctors will think it's carcinoid syndrome or another diarrheal syndrome and increase the dose of somatostatin analogs, which is, of course, counterproductive.
Right. I think we got a question there.
Let's see. I do not have any access to net specialists in my town. I'm wearing burning question. So the question is, does lanreotide cause pancreatitis? I mean, lanreotide can certainly cause crampy abdominal pain. I don't think we know that it can cause actual inflammation of the pancreas.
Yeah, not that I'm aware of either.
And it may be reported here and there. The problem is that unless you do a randomized study in a very large number of patients, it's always hard for doctors to figure out if something is happening because of the treatment or because of the disease or because of something completely unrelated to either. So
Yeah, the only setting that I would imagine pancreatitis is kind of a three-step, kind of 6 degrees of something. But the injections cause the gallbladder to also be lazy, and gallstones can form when the bile is not moving around, and one of those stones can get lodged in the plumbing, if you will, and that can lead to pancreatitis. But in this setting where you had, without giving direct medical advice, you had symptoms within 10 minutes of the shot, wouldn't quite fit that scenario.
right. So anyway, I look forward to seeing you hopefully soon. And if this tumor is just confined to the pancreas, hopefully it's surgically resectable.
Okay.
Anyone have, okay, well, we have an answer to that.
Gotcha.
So usually the somatostatin analogs are well tolerated, but obviously not 100%. Occasionally we have patients who develop issues, and patients with tumors in the head of the pancreas unfortunately can get pancreatitis because the tumors can block the pancreatic duct.
Yep, I've seen that as well.
Anyone else have any comments or questions?
While we're waiting for a few maybe to come in, with the injections, I always say that with any drug, if you prescribe it long enough, you tend to see like any and every potential side effect, right? And so some of the more strange potential side effects, and I have this kind of axiom or rule of thumb that if somebody develops symptoms and they're on a drug, it's always the drug until proven otherwise, right? You could prove otherwise, but it's always the drug until you do that. And so I've seen patients have some joint pains with it. I saw patients have some hair thinning with it. Again, as Dr. Strosberg said, it's hard to attribute always whatever symptoms to the drug or other things, especially on a clinical trial. I saw some patients with some what we call neuropsychiatric changes. So one patient would get, really depressed shortly after, and it clearly coincided with the injection. It is a hormone. I've seen it twice, maybe once, one for sure that it seemed to have a correlation. So I think if you're having a new symptom and you're on a medication, it's worth discussing with your doctor, like, hey, could this be causing these symptoms? And, again, if you were in the clinic with me, I'd say yes, until we can prove it's something else. So just a note about the somatostatin analogs that, I've seen some crazier side effects.
Let's see. No, okay, well, again, Amanda, look forward to seeing you. Alicia, if you could call at 813-745-5553. I'd like to hear more before the meeting on Tuesday so we can maybe add additional tests if necessary. Last chance, anyone? Let's see, lost most of her hair in one gray, but growing back. All right, well, hair graying is something or change in hair color is something we see with several of our treatments, and it's not just neuroendocrine tumor treatments. I mean, patients who lose their hair from various chemotherapy drugs can, they can start out with straight hair and then it grows back as curly.
Yep.
Or gray. Anyway, I want to thank all the patients who joined us, and Jason, thank you very much. That was really fantastic, and I look forward to seeing you next week.
Yeah, I look forward to it too, and thank you to Maya for putting this together and organizing, and thank you for having me. I was supposed to be here a few months ago, and life got in the way, and so I'm really thankful to be able to be here with everyone today.
Sounds great. Appreciate it.
Thank you.
Thanks.
Bye-bye.